Hello. Today we're going to do an integrated osteopathic structural exam and just physical examination of this patient. He's coming in with a chief complaint of chest pain today. We've already, he's already hooked up to the monitors. We see a 5 lead EKG. We see some pulse ox. We see his blood pressure. All of these are reassuring. His EKG isn't showing any ST changes. It's not showing any indications of maybe a PE if you like the EKG for that. There's no signs of any changes in his blood pressure from his baseline rate. His pulse ox is 99/100. So just walking in with that in mind, we don't have anything more pressing going on. We're not necessarily thinking of like a pneumothorax, a myocardial infarction. We're not thinking of like massive PE. We're still going to evaluate the heart and the lungs and some of the GI system. But just up front, we don't think it's necessarily an emergency right now. So we have a drape that we can use at any time if the patient feels uncomfortable. Do you feel comfortable to go ahead and have an exam?
I do feel comfortable.
Thank you. So we're gonna do a heart and lung exam. We're also gonna maybe look at some of the GI system and some of the muscular skeletal system. Okay. So I'm just gonna place my stethoscope. It's gonna go underneath your shirt if that's okay with you.
Sure.
We're going to start out anteriorly. I'm going to listen to the apex of his lungs first and then start integrating the cardiac and respiratory physical exam at the same time. So just take a deep breath in and out through your mouth. Just sort of normal rate. Again. Great. Alright, so that was over the shirt. So we're going to do it again under the shirt real quick. If you feel lightheaded at any time, let me know, and I will. We can stop the exam and do something else to sort of help you out with that. Great. So now we're moving into the aortic listening post. I'm listening to both his heart and his lungs at the same time right now. And then over here in the pulmonic listening post. Great. Dropping down into a lung field here. As well as feeling his pulse here. We're not feeling a pulse-to-pulse variation, so that gives us reassurance that he's not necessarily having cardiac tamponade, which is changing with inspiration and expiration. We're listening to the tricuspid listening post, and now the mitral listening post. And everything sounds clear, both in the lungs and his heart. Sounds like he has a regular rate and rhythm. No, we hear S1, S2, but no extra sounds. Do you mind leaning forward real quick? And deep breath. Great. And we don't hear any scratchiness during any of this. And also in the leaning forward position where you could most likely hear sort of a friction rub. And we don't hear any of that right now. So I'm just going to take a look at you while you take some breath. Just evaluate how the ribs are moving, how the chest is moving. So from the front, feeling these top ribs move. Okay, do you mind if I place my hands up across your chest?
Sure.
Okay. And then I'm going to have to come down on these ribs. Everything's moving evenly and symmetrically. Go ahead, one more. Perfect. So now we're going to evaluate some of the tender points. If anything feels tender while I do this, please let me know. And I will note that and we'll take that in consideration.
Okay.
So we're just going to start up in the traps. Okay, we're going on the clavicle. Nothing here. Calling out towards the pecs. Any pain? No pain. So we're not having any pain. I don't feel any tissue texture changes, any sort of change, and he had no change in range of motion with respiration. So now we're going to feel some anterior Chapman's points, looking at the lungs, the heart, some of the esophagus, and some of the GI structures. And we're not feeling any tissue texture changes or any bogginess here. Okay, so you can see we saw some pain to palpation. It looks like along the second rib at the costochondral junction. So that goes along with the chief complaint of chest pain. Also, he had a little bit of pain with respiration and positional change and laying on his stomach. He told me beforehand. So he had to lay on his back last night to sleep. as well as pain that was reproduced with palpation, makes us think chondrochondritis, or maybe he had a direct contact between him and another force between the rib and the costochondral angle. We'll go ahead and evaluate the back as well. Do you want to scoot forward a little bit in the chair? So we're going to listen to all of the listening posts in the back, as well as evaluate for viscerosomatic reflex, focusing on T1 to T5, as well as T2 to T6, all evaluating the lungs, the heart, and those viscerosomatic reflexes, as well as some of the as well as just evaluating the musculature in this area. So we're listening on skin now. Deep breath. Great. And while I'm doing this, I'm now evaluating for any abnormal curvature in his back, as well as listening and feeling for any ropiness or bogginess. I'm not noticing any tissue texture changes while palpating his back, or any rotation of the thoracic or even the lower cervical spine or the upper lumbar spine at this time point. And then again. Great. Now we're just going to listen around the side again on the left side. That's just a little extra. We'll listen again on the right side just to make sure we hit the right middle lobe. Beautiful. All of the lungs kind of clear. I didn't notice any tissue texture changes, any asymmetry, any ropiness or bogginess in the back, as well as the posterior Chapman's points. There was no change in the tissue in either of those locations. Through exploring the HPI a little bit, he doesn't have any history of GERD, any acid reflux, any history of taking multiple aspirin or pain medications that make you think of like a peptic ulcer disease. He hasn't had any retching or anything that's making us think about the esophagus. So along with that, in our physical exam, we're thinking more along the costochondritis, sort of musculoskeletal type findings that we saw in this integrated exam. Thank you for watching the exam.